to make it as simple as possible. This is a part of your clinical posting, endocrinology module, third year, that is third professional MBBS. Bismillahirrahmanirrahim. Coming back to the topic. Common diseases of ear, we will further subdivide into 3 categories. Dealing one by one: diseases of external ear, diseases of middle ear, and diseases of inner ear. As the ear can be divided into 3 main parts: external ear starting from the pinna, which is the collection point of sound waves, concha, external auditory canal, and ending up to the tympanic membrane. This part wholly is called external ear. Okay. Then starting from the tympanic membrane up till the windows, round window and oval window, this part of the ear is called the middle ear, or it's also called tympanum. So this is the stapes, the ossicle of the ear, which is fitting into the oval window. So this whole is the part of the middle ear. And the inner part starting from the windows up till the vestibulocochlear nerve, this whole sensory neural part is the inner ear. So these are the 3 main parts of the ear, and we will be dealing with the common problems of these parts of the ear. I will check it out. Somebody is saying that presentation is not visible to us. Okay, the slides are not coming. I'll check it out. स्लाइड्स में जानी हूं तक पहली स्लाइड ही नहीं देंगे, ये वाली नेक्स्ट क्लिक और नीचे वाला प्रेस करना पड़ेगा, ये वाला, लेकिन उनके पास क्यों नहीं आ रही है हवाई कुछ करेगा और वाला Hello students, are they visible to you now? Please reply. No, we're going back to the presentations. Is this visible now? Yes, thank you. Next one. Slide showing. Okay, thank you. So we have seen the 3 parts of the ear, right? External ear, middle ear, and the inner ear. Now, dealing the external ear problem first. Dealing with the first part of the ear, that is external ear, the main problems which the patients come to ENT with are the wax in the ear, impacted wax. Wax is a normal secretion, but if it gets hard, it creates a problem, blockading in the ear, heaviness in the ear. So it becomes a problem then when it becomes hard and infected. So wax in the ear is a common problem. Boil ear is the second common relating to external ear. Boil ear is also called furuncle. And third most common condition of external ear is OTOMYCOSIS, that is the fungus in the ear. And the fourth most common problems, which is usually coming to ENT emergency via emergency department, is the foreign body ear. And the last condition of the external ear is malignant, otitis externa, one of the types of otitis externa which we come across in daily problems. So the most common problem is the wax in the ear. You know that wax is the normal secretion. Wax is secretion from the external ear canal called cerumen or simply called ear wax. What is the function of wax? Wax protects ear from dust, foreign particles and microorganisms, and also from water. Sometimes water become irritant for the external ear. So wax make it waterproof and safe the external auditory canal. Normally, excess wax finds out of the ear canal. What is the normal way of clearing the extra wax? When you take bath, come out of the washroom, use the towel. Gently rub the towel against the external auditory meatus. That is the opening to the external auditory canal. So while rubbing, the extra wax is washed out or wiped off, and there is no way to use the buds. So it is contraindicated, forbidden not to use cotton buds or Q-tips in your external auditory canal. So when more wax is produced, some persons they have the tendency to produce more wax by the ceruminous glands in the external auditory canal. It becomes hard. The wax becomes hard from golden to brown, dark brown. It becomes black, and then it causes ear blockage or blockage. That is the block in the external auditory canal, which may lead to deafness, impairment of hearing. So these are the signs and symptoms of impacted wax. Okay, there is a feeling of fullness of ear. What is a symptom? What the patient tells the doctor is a symptom, and what is a sign? What the doctor sees in the patient is the sign. So what is a symptom that a patient would be telling the doctor that I have a feeling of fullness of ear? And the third is the hearing impairment. We don't call a hearing loss directly, but we say that the patient is having some impairment in hearing. And because there is a block in the conducting pathway of sound waves, so this type of hearing impairment would be called conductive hearing impairment. And impacted wax may be responsible for another symptom that is called tinnitus. Tinnitus means ringing in ears. The blockage in the ear can lead to feeling of something ringing inside the ear, which is a subjective feeling of the patient. And what is a sign? When the doctor tries to see in the canal with the help of an otoscope, this is called otoscopy or otoscopic examination. The black hard wax is found in the canal. As you can see in this diagram, Dr. K.K. Karate is trying to remove the hard wax with the means of this metallic suction probe. And this is occluding the canal and is responsible for the feeling of fullness in the ear by the patient and conductive hearing impairment. And sometimes responsible for tinnitus, that is ringing in the ears. So this is a common condition we're dealing with a wax in the ear, which is infected inside. How to deal, how to manage, how to treat the infected earwax? It is by softening and instilling soda glycerine ear drops for at least 3 days, then cleaning the ear by ear syringing. If you have some inquiry, you can put the question on the chat side by side. Another simple method, the home remedy, is if you have olive oil available and a dropper is available, you can soften the earwax by putting some olive oil drops, so that the soda, by putting the olive oil, the impacted wax, hard wax gets softened. Then on the 3rd to 4th day, you get it syringed by the ENT doctor. So there are basically main method is soda glycerine ear drops, which is available at every pharmaceutical store. So you put 3 drops 3 times a day, and then get it suctioned in ENT clinic. The second most condition which we come across in the external ear is the boil or furuncle in the ear canal. Wherever there is a hair follicle, hairs in the body, the suppurative inflammation of the hair follicle is called voil or furuncle, right? Voil or furuncle can be found anywhere where there are hair or hair follicles found. For example, in the part of the ear, the external ear, it is outer cartilaginous part. Which cartilage is there? Elastic cartilage. So the external auditory canal has got two parts, outer cartilaginous and inner bony. So hair are lying only in the external outer cartilaginous part, outer 1/3. So if there is inflammation or infection by the Staph aureus, so that Staph aureus can lead to acute suppurative inflammation of the hair follicle, which is commonly called furuncle. As it happens in the cartilaginous part, it is very, very painful for the patient. Why? Because the skin in the cartilaginous part is tightly adherent to the underlying cartilage. So this is responsible for severe pain. It doesn't find space to spread, and that gives severe pain to the patient if he or she develops a voil in the external auditory canal. So positive organism, the most common is Staph aureus, the gram-positive organism, and the clinical features. Patient complaints of severe pain in ear canal, commonly found in people using earbuds or earphones and habitual of scratching their ear. So it is also found in the swimmers and those people who are fond of using Q-burs or Q-tips and scratching the ear frequently. The question on the chat side is that how hard wax is causing tinnitus. It is simply because of blockade in the ear. The patient is having hearing impairment, and this may be leading to, not always, but because of the blockade in the ear, the patient can have the feeling of tinnitus. He or she may complain of that there is something inside the ear which is ringing continuously. This is simply because of hard wax impacting the canal. So next, this is a picture of the voil ear. It is just at the meatus, that is the gateway to the external auditory canal. As you can see, it is also simply called a pimple. Pimple in the external auditory canal is just at the opening. It is about to suppurate. When the fluctuation is positive, the pus may burst out of it, and sometimes may be needing incision drainage. The treatment of voil ear, whenever you are asked that how to manage a case of a voil ear, it comes under 4 headings. So there are 4 main headings for the management of a case. First, you take history. The second is the examination. Third is investigations. If there are some pertinent investigations, we'll ask the patient to go for. And the last is the treatment. So here we are dealing with the treatment. If the voil happens, and we make a diagnosis on the basis of history and examination. I think investigation is not relevant in this case because it is simply based on examination and history. So if you establish a diagnosis of voil ear, you give antibiotic coverage, Staphylococcus aureus. What is the best antibiotic? Penicillin and its derivatives like amoxicillin and ampicillin, or if you better go for OTOMYCOSIS, which is a combination of clavulanic acid and amoxicillin. And another remedy is a dispensary product, dispensing item, which is usually available at Boston Medicos. We ask for Times Medicos. We give the prescription. They make this medicine for the patient. 25% ectamol glycerin, and a wick is prepared in it, impregnated with ectamol glycerin. 25% is placed in the canal, soothes the pain and helps in bursting out the voil. While you put the wick inside the canal, it helps in bursting out the furuncle or voil. Abscess is burst out and helps in relieving the severe pain experienced by the patient. Now, the third most common condition we counter in external auditory canal is OTOMYCOSIS or fungus in the ear. The most common fungus inside the external ear is Aspergillus. Aspergillus niger is the full name, which is commonly found in external ear. Aspergillus and niger means black. A black spores is usually found along a white foamy background, which when you do otoscopy, you are able to see such a picture that white foamy background with black spores are visible. And candida is a white fungus, which is the second most common after aspergillus, found in the external or ear canal. Predisposing factors: fungus is usually promoted in moist environments, like the summer season where severe perspiration, in rainy season, putting ear drops which are formulated in water base. So ear drops sometimes available in the market are based in water, so it may promote fungal infection. So if you are prescribing ear drops, it's better to use those ear drops which are manufactured in oil base, not water based. Swimmers, their ears are usually wet. It's advisable to use ear plugs while you're swimming, right? Otoria means discharge from the ear. If it is continuously discharge coming out of the middle ear and constantly infecting the external auditory canal, it may lead to the predisposing factor. It can act as a predisposing factor for the proliferation of fungus in the external canal, auditory canal. Clinical features: if the patient has developed otomycosis, he or she may be complaining of pain, which may be mild to severe. Itching is a very common feature of fungus in the ear. If patient develops otomycosis, auto means ear and mycosis means fungus. So if the patient develops otomycosis, he would be frequently complaining of itching. Yes, somebody is asking that point on ear drops to be repeated. I am telling that ear drops themselves can help in proliferation of otomycosis, that is fungus in the ear. When these ear drops can be harmful or risk factor for otomycosis, when they are prepared in water base, because water itself helps in promoting fungus. So when you are prescribing the ear drops for the patient, then you try to prescribe those ear drops which are based in oil, not in water, not manufactured in oil base, in water base. So this is to avoid otomycosis. The patient may again be, because of blockage, it may be complaining of tinnitus, deafness, not truly deafness, but impairment of hearing, because it is occluding the canal. Impairment of hearing would be conductive type, because the canal is occluded, the conductive pathway of sound is occluded. So impairment of hearing would be conductive type. On examination, spores and mycelia would be visible on otoscopy. Mycelia are these white filaments which you can see while doing otoscopy, putting in otoscope in the canal and seeing the picture like this inside the canal, inside the external ear. And black spores are sometimes like this. In Aspergillus niger, this white foamy background and the black spores are visible. In Aspergillus niger, which is the most common type of fungus in the external canal. What is the treatment? We try to remove this fungal ball by suctioning. Antifungal drops or ointments are put inside or instilled inside the canal, external auditory canal. Nystatin are the antifungal drops which are commonly used for candida infection. Or when the fungus is candida type, use the nystatin antifungal drops. Conazoles are a group of antifungal agents which are very suitable for Aspergillus niger. They are available in ointment forms and drops form. And the most important factor to avoid is avoid water entry into the canal, because once the fungus develops, it becomes very resistant, very difficult to get heat. So in all the situations, water is to be avoided. So whenever the patient comes with otomycosis to ENT clinic, you always advise patient that whenever you take bath, or sewing, you always have to plug your ear. In daily situations when you're going to take bath, especially in summer, you ask the patient, advise the patient that you use a cotton ball, small cotton ball, impregnate with Vaseline or oil, whichever is available at your home, and you have to plug your ear before taking bath to avoid water entry into the canal. Otherwise, fungus won't be healed. Now, other condition which is very common and is usually seen in children and coming in our emergency situations, emergencies from ER department, is the foreign body ear. Usually, the mentally retarded children or naughty children, very young, they want to just feel the sensation they get when they put some foreign body inside their exits like external auditory canal, nose, and throat. For example, a piece of rubber, chalia, a bead, such foreign bodies are very common with the children. They usually put in their ear. Size is the most common site of infection is the isthmus. Generally speaking, isthmus is the word is used for the narrowest part of any anatomical territory. So in the external ear, isthmus is a part where the external auditory cartilaginous part is merging with the bony external auditory canal part. So it is the junction of the cartilage and bone, which is the narrowest part of the external auditory canal, and it is usually the site of infection introduced by the child in his body. So the types can be animate, there is a living body like insect, or inanimate, which is non-living, like with any vegetable origin or non-vegetable, plastic waste, so on. Signs and symptoms: animate if the patient's inside the ear is a living body, there is intense irritation. For example, an insect gets entry into the external auditory canal, then it gives rise to intense irritation felt by the patient. He would be constantly in discomfort, and it is extremely painful because that insect is damaging the canal inside, and that insect may perforate the tympanic membrane or eardrum. Vegetable origin foreign bodies are usually inert, like bee, any vegetable origin like a pea. It is inert, dry, but it swells up and causes dampness inside the moisture inside the external auditory canal, and it can lead to, because of inflammation and the reaction to body towards the foreign body, is secondary otitis externa, and is difficult to remove because it gets swelled up and usually may lead to bleeding while removal. So can be sharp bleeding. Inert foreign body is like inert foreign body, example is stone, and there is sometimes no symptoms because there is no body reaction towards it, towards this inert foreign body. Infected, if the foreign body remains infected for a longer time, it can cause conductive type of hearing impairment, not true deafness. How to manage the foreign body? It depends upon the type of foreign body, the population of the patient, and facilities available. If the patient is cooperative and foreign body is clearly visible just outside towards the outer part of the canal, then it is easily removed by the use of probe. Ear probe, when you come to our ward, we'll show the instrument. This is a crocodile instrument which is shown in the diagram. This is called alligator forceps or crocodile forceps. If it is a piece of paper or a tissue paper, you can get hold of it by means of this crocodile forceps or alligator forceps, and you can easily remove. The patient is cooperative under a very good light, that is very good illumination, you can remove. Or otherwise, if it is animate, this is a living insect, for example, you have to first kill that patient so it is drowned. For example, by instilling local anesthesia, 4% xylocaine in syringe, you put the local anesthesia liquid in the external canal so that the insect gets drowned or killed, and then you can remove by using this instrument. Again, that is the crocodile forceps. But if the foreign body is vegetable origin, like a pea seed, then you gently syringe it with alcohol solution, or you remove it rounded peel by blunt round hook. If the foreign bodies are sharp, then you remove the forceps for removing it, like a pin or something like that. And if the foreign body is stone, which is commonly impacted by the children, then it is removed by syringe. If the patient is cooperative, it can be removed without anesthesia. But if the patient is not cooperative and you think that you can damage the canal or you can damage the tympanic membrane, then you have to prepare the patient for GA, and under microscopic vision you try to remove the foreign body from external auditory canal, trying not to damage the tympanic membrane, not to cause bleeding. And these are the children which are put under GA for removal of foreign body are usually children, unapprehensive, not cooperative, very frightened, and the foreign body is deeply impacted, not easily removed without anesthesia. So these are patients kept under GA. Failed attempts, several attempts have been made, but doctor is not successful in removal of foreign body. Then the patient is put under GA, and under GA the foreign body is removed. And other condition is that external auditory canal or meatus gets inflamed, swollen, and the canal becomes narrow. So in those conditions, the patient is again kept under GA and the foreign body is removed. Rarely foreign bodies, they enter the middle ear again because of the several attempts which have been failed. So sometimes the foreign body from the external auditory canal gets entered into the middle ear, and then in those conditions, sometimes we have to remove the foreign body in the middle ear, on the posterior part of the mastoid, that is called antrum, and sometimes tympanotomy has to be done. Or we can approach via post-oral. Major surgery is done. Hello, so this was about the foreign body is impacted in their management, how to deal with it. So the last condition which is encountered in external ear is malignant otitis. Different types of otitis, external, diffuse, and localized. But this type of otitis externa, which is of serious type, it is not malignant. Does not mean that it is a cancer, but because of its seriousness, it is called malignant otitis externa, a serious type of otitis externa. This is also called, synonym is necrotizing otitis externa. So malignant otitis externa is also called necrotizing otitis externa because it is so serious, it is so invasive that it is necrotizing. It causes necrosis of the surrounding areas. It is an invasive bacterial infection affecting the external auditory canal and sometimes reaching to skull base because of its invasiveness. It is a complication of otitis externa. It's not a simple otitis externa, but rather a complication of otitis externa in immunocompromised and diabetic patients. Why? What is otitis externa? It's the inflammation of the mucosa of external ear. But if the patient is immunocompromised or the patient is of uncontrolled diabetes, then malignant otitis externa can occur. Positive agent is Pseudomonas aeruginosa. You must be knowing that Pseudomonas aeruginosa is a gram-negative bacterium, and in 95% cases of malignant otitis externa, this is the main culprit. This is the main organism which is involved. In case of malignant otitis externa, clinical features, what the patient is telling to the doctor that there is severe pain in the ear, and this pain is aggravated on hand movements. There is discharge from the ear that is called otorrhea, which is usually foul smelling, can be blood stained, mostly greenish because of Pseudomonas aeruginosa. When you describe the discharge from the ear in patients with malignant otitis media, you must be knowing the features characteristic of this condition, and you must be knowing the cause behind it. Why it is foul smelling, why it is blood stained, why it is greenish. It is foul smelling because this is an erosive type of otitis externa. This is necrotizing type of otitis externa, which is eroding the bone, which is causing inflammation of the bone surrounding the canal, and this leads to foul smell. So the cause of foul smell is otitis, inflammation of the bones and erosion of the bones. Why it is blood stained? Because it's usually associated with colostoma. It is a pathological entity which is formed in chronic discharging ear patients, and whenever there is a pathology, it's always covered with healing tissue, and you must be reading or studying pathology to know what is granulation tissue. It's a type of healing tissue which is surrounding a pathological entity, and it's formed by new vascularization tissue, fibrosis. And new vascularization is usually formed by delicate new vessels which are very fragile and they are easy to bleed on touch. And why the discharge is greenish? Again, because of the most important organism involved in such inflammation, that is Pseudomonas aeruginosa, gram-negative organism, which is found responsible in 95% of such cases. And this form green colonies. That's why the discharge is of usually green in color. Facial nerve may get involved in vast cases if the pathology is invading the facial canal. Then it may involve the facial nerve, and the patient may present with facial palsy. Investigation required in malignant otitis externa is oral pus. What do? We take the pus which is coming out of the canal or the ear. We take the pus specimen in test tube and send the pus for culture sensitivity from the infected ear. Wait for the report. It's better to wait for the report so we can give the targeted antibiotic according to the culture sensitivity report. What the culture sensitivity report tells you about, it tells you about the particular organism involved in the pathology and what are the antibiotics which would be suitably targeting that organism. For example, Pseudomonas aeruginosa, quinolones are the typical antibiotics which are killing that Pseudomonas, for example, ciprofloxacin and levofloxacin. So it's better to go for oral pus. And the second important investigation sometimes required when the disease is so extensive, eroding the surrounding areas. So in such cases, we advise also for CT scan of the temporal region which is affected side in advanced cases to see the extent of invasion and the bony involvements. The treatment of malignant otitis externa, as you know that Pseudomonas aeruginosa is the most common organism involved. So anti-pseudomonal antibiotic is the mainstay of treatment, especially fluoroquinolones like ciprofloxacin, levofloxacin. Sometimes it is prolonged for 3 months. Common diseases of the middle ear. Now we have covered the common problems of external ear. Now we come to the second part of the middle ear, that is the middle ear, and the common problems in the middle ear are acute otitis media with effusion, chronic suppurative otitis media, and lastly the otosclerosis. Acute otitis media. What is otitis? Otitis, what means? Here, itis means inflammation. Otitis is the inflammation of the ear. And what is media? The middle ear. No, it's not simply the middle ear, but otitis media means inflammation of the mucosa of the middle ear cleft. So whenever you are asked about the definition of otitis media, you say that it is the inflammation of the mucosa of the middle ear cleft. So going back to embryology, Developmental anatomy. The middle ear cleft is developed as a whole unit and it contains three parts. Starting from medial side, medially starting we have the eustachian tube. In the middle we have the middle ear cavity, and posteriorly back we have the mastoid ear cell system, the whole mastoid ear cell system. So it's inflammation of one or all three units of this cleft, middle ear cleft. This is called otitis media. And what is the difference between acute and chronic? Acute means the disease of severe illness. Severity is more, but the duration is short. It's like 10 days, 7 to 10 days, but not more than 2 weeks. So such a otitis media, which is of short duration, more in severity, and not prolonging for 2 weeks, then it's called acute otitis media. Second condition is otitis media diffusion, when there is intact tympanic membrane, sterile fluid collection in the middle ear. We would be dealing in detail. And the third condition of the middle ear, which is very, very common, and such patients are admitted for surgery. Mastoid surgeries are chronic suppurative otitis media. What do the patients complain? They complain of chronic discharging ear for years and years, but chronic hair in the ear infection is referred to the condition when it is lasting for more than 3 months. So in ear condition, otitis media, again the inflammation of the mucosa of the middle ear cleft, when it is due to disease course is more than 3 months, and it is added with pus formation. Suppuration means pus formation. On one hand, it is chronic, lasting for more than 3 months, and on the other hand, it is classified or characterized by pus formation. Such an otitis media is called chronic suppurative otitis media. Otosclerosis is another condition. We'll tell you in detail, which is less important for third years. This is a condition of otitis media. This is what you see in otoscopy. This is a condition. You can see the angle of median. This is umbo point. This is the cone of light. This is a normal picture of a tympanic membrane. Clearly white in appearance, and this is shiny reflection seen. Here comes the picture of otitis media. You can see the leash of blood vessels. The tympanic membrane is congested, red in appearance. The cone of light is not so visible, and the membrane, that is the tympanic membrane or eardrum, is bulging out laterally. So this is a picture which is found in otoscopy in cases of otitis media. Acute otitis media is usually seen in children with severe pain in the ear when the membrane is still intact. So the patient may be complaining of otalgia. Pain in the ear is called otalgia. Second condition is otorrhea, discharge from the ear, hearing loss, or simply it's called impairment of hearing. In this condition, again, it would be conductive type of hearing loss. Vertigo may sometimes be very rare, but sometimes may be present if the condition is running towards or going ahead towards the complications. Non-specific, which is sometimes found because when suppuration inside, there can be systemic signs like fever, irritability, patient is irritable, lethargic, not taking food, vomiting, diarrhea may sometimes be present. But the main is the stages of suppurative otitis media is mainly because of eustachian tube occlusion. Then comes a stage when the pus is still not formed, so it is called pre-suppuration. Then comes a stage of suppuration or pus formation. Then a stage of resolution, when the disease of otitis media gets healed or is getting better, or if it's not healed at the right time, then it may be two-stage of complication. This is actually a topic that in detail would be dealt in while you will be in 4th year, inshallah. Serous otitis media is another condition of the middle ear. You can say that it's inflammation of the middle ear resulting from incomplete resolution of the fluid, or sometimes it may arise as a de novo. Basically, it is because of the eustachian tube block, and middle ear pressure rises, the fluid starts collecting inside the middle ear cavity. This is basically in sterile fluid, or this is simply transudate from the blood vessels in the mucosa of the middle ear. It may contain pathogenic bacteria when it becomes suppurated, and most commonly in children. The predisposing factors, as I said, is eustachian tube. Eustachian tube is a tube which is lined by respiratory epithelium. One end is in the nasopharynx, eustachian tube, and the other end is the anterior wall of the middle ear. So it's a connecting tube between the airway and the middle ear, starting from nasopharynx lateral wall. Where it's inflammatory process, there can be an inflammatory process in the nasopharynx, which is carried by eustachian tube to the middle ear. Eustachian tube is also called auditory tube. A predisposing factor when there is nasal allergy, mostly common in children. Allergic manifestations are there, nasal blockage or runny nose, hypertrophic adenoids, which are adenoid collections in the nasopharynx. This is the most common condition in the children under 11 years or before puberty. They may lead to eustachian tube block and in turn leading to serous otitis media, which is collection of fluid inside the middle ear cavity because of imbalance of pressure. Benign or malignant neoplasms inside the nasopharynx can again lead to auditory tube or eustachian tube blockage and leading to serous otitis media, that is collection in the middle ear of sterile fluid without pathogenic bacteria initially and in presence of intact membrane, that is eardrum is still intact in serous otitis media. Another name of serous otitis media is otitis media with fusion, and it's also sometimes called glue ear. Glue ear. Glue means gone. Its consistency inside the middle ear of the fluid is like a glue. So why it's called a glue? Because the secretions from the glands are mucinous. What gland? Which glands? The glands which are situated in the wall of the middle ear, they have a mucinous type of secretion, and that forms a glue inside the middle ear cavity. So serous otitis media is also called glue ear or otitis media with effusion. Symptoms of otitis media with effusion: the patients may be asymptomatic, or patient may experience ear discomfort, impairment of hearing, tinnitus because of blockage. There is fluid collected in the middle ear, which is creating impedance in the conductive pathway. Possibly vertigo, which is very, very rare, sometimes found in complicated cases, and again feeling of ear fullness because there is a fluid inside the middle ear. Signs what the doctor sees in the patient. In patients with serous otitis media, tympanic membrane retraction, his tympanic membrane is inverted, retracted inwards medially, or light reflex is slightly displaced, and the landmarks are attenuated. They become prominent like pendulum areas. For the blood vessels in the mucous membrane in the middle ear, they are producing transudate, which is responsible for collection of fluid in the middle ear. On otoscopy, the tympanic membrane may appear amber-colored or gray in color. Tympanic membrane would be immobile because of the fluid collecting behind the tympanic membrane in the middle. And air fluid level or bubbles of air may be seen through the tympanic membrane because of the ingoing fluid collection process in the middle ear cavity, and conductive type of hearing impairment can happen. Otitis media, coming back to the otitis media, which is inflammation of the mucosa of the middle ear cleft. It is eustachian tube, middle ear cavity, and the mastoid ear cell system. Treatment is medical. We will give the proper antibiotic, painkillers according if there is pain. If there is fever, we will give the patient antipyretic. Oral toilet means cleaning the air and keeping the air dry as much as possible. Suction clearing is done when there is discharge and the membrane has been perforated in complicated cases. Topical antibiotics are sometimes advised in the form of drops, and systemic antibiotics, if the pus is coming out of the canal, then we have to send a specimen of pus and wait for consistency report to come, and then it's better to start the targeted antibiotics depending upon the culture sensitivity report. Decongestants are very much important because in otitis media, the main important positive agent is nasal blockage and eustachian tube catarrh or blockage again. So decongestant can help in finding relief. Analgesics according to the symptoms. Analgesics are given for pain relief and antibiotics for fever. Surgical management sometimes required in otitis media when there's too much fluid and the membrane is about to burst out with the pus inside otitis media. Then myringotomy means creating a hole in the eardrum. Myringes means tympanic membrane. And otomy means to create a hole. So we'll create a hole surgically. It is called myringotomy. And we put a ventilation tube, or it's called grommet, to have the continuous ventilation or drainage from the material to the stream. Myringotomy can be laser-assisted advancement in technology. Tympanostomy may be required, not up to your level. Mastoidectomy may sometimes be required when the medical treatment is not sufficient, is not responding, and the disease is still going on. And sometimes mastoidectomy is done and whole disease mastoidal cell systems are removed under microscope. Myeloplasty is sometimes to be requiring if the ossicles are damaged, we have to replace them. A very important condition, otosclerosis, this is hardening of the foot plate of the stapes. This is the area of the oval window, and this is the foot plate of stapes. Is what the hard bone is replaced by spongy bone. I'm going through it very quickly because this is a very difficult topic for third year level, so just we are not supposed to ask your level. This is just the site of otosclerosis, but you must know what is otosclerosis. This is the hard bone which has been replaced by spongy bone. It is autosomal dominant type of disease and may cause impairment of hearing. Hormonal influence is important. It is exaggerated in pregnancy. It mostly involves foot plate of stapes. Slowly progressive hearing loss is noted by the patient. Is bilateral. Age is 15 to 45. Women are more voice affected than males, and pregnancy and estrogen therapy is a predisposing factor. You can see under microscope, this is the spongy bone replacing the hard bone at the foot plate of stapes. Short sign or flamingo sign is seen under microscope. A red sign, which is indicative of the active stage of otosclerosis. And tuning-fork test is done, then you are able to see conductive hearing loss in such patient. And the tuning fork used in clinical practice is of 512 Hz per frequency. Tympanosclerosis, we have to differentiate otosclerosis from different conditions. I'm skipping this because it's higher for your level. This is the very common audiological testing test which is done. This is called pure tone audiogram. This is called PTA because at a single time or single frequency is let it be heard by the patient, and we record in the graph when the patient is able to hear a particular sound at a particular frequency. You will see these are the frequencies and these are the sound intensities in dB. dB means decibel. Decibel is a unit of intensity of sound, and this is the frequency. So this graph is plotted between the intensity of sound and the frequency of sound. And normally there should be no gap between the conductive air conduction and the bone conduction. But if there is a gap of 30 or more than 20, then we say there is an air-bone gap between the two grafts and the patient is suffering from conductive hearing loss, which is commonly found in otosclerosis and other conditions. Now, the most important type is CSOM, chronic suppurative otitis media. When you are asked to the definition about chronic suppurative otitis media, you can say chronic means more than 3 months duration. Otitis media means inflammation of the middle ear cleft, and suppurative means when it is associated with pus formation. So you must be knowing what is middle ear cleft. Starting immediately, we have this first structure that is eustachian tube, starting from the lateral wall of the nasopharynx, going laterally towards the middle ear. This eustachian tube is called auditory tube also, and this is entering into the anterior wall of the middle ear. This is a promontory, and this is the whole is the middle ear cavity. This is a building of promontory. So auditory tube, middle ear cavity, and behind, posteriorly and superiorly is the mastoid air cell system. So this whole thing is called middle ear cleft. So inflammation of the middle ear cleft is called otitis media, and is of more than 3 months duration. It is called chronic otitis media, and when it is added with a pus formation, then it's called chronic suppurative otitis media. So it's basically of two types. It's very necessary to differentiate between the two types of chronic suppurative otitis media. One is tubotympanic type, is mostly common in children. As the name indicates, this is because of tubal occlusion. This is eustachian tube occlusion, usually seen in allergic patients with nasal blockade or retinoids in children, can cause a blockade of eustachian tube and in turn leading to inflammation of the tympanic cavity. So such type of CSOM is tubotympanic type. And aticoantral, which is most common, most serious type in adults, is aticoantral, because vertic is the uppermost part of the middle ear cavity, which is connecting with the antral part. Is the biggest cell of the mastoid air cell system. It's connecting with the middle cavity. This is usually a serious type of CSOM found in adults, and it's called unsafe type, while tubotympanic is safe type of CSOM. So we have to see the main differentiating points between the tubotympanic type and the aticoantral type. Tubotympanic type is found more common in children, or mostly in children, and aticoantral type of CSOM is mostly found in adults. The discharge in tubotympanic from the ear is mucopurulent, like the nosy secretion, white, transparent, blue-like. But in aticoantral type, it is purulent, it is pussy. Pus is formed coming out of the ear canal. And tubotympanic type, the discharge is profuse, means more in amount, while aticoantral is scanty, less in amount. Tubotympanic discharge is odorless, without any smell, while in aticoantral type it is foul smelling. Reason you know, osteitis, that is inflammation of bone and erosion of bone. The aticoantral type is unsafe type, serious type, because it erodes the bone, it inflames the bone, and it can lead to foul smelling discharge. Now, coming back to tubotympanic, discharge is not blood stained. In aticoantral type, this is blood stained. Why? Because of formation of granulation tissue with new delicate vessels, it leads to blood stains. Deafness. In tubotympanic, this is conductive, mild to moderate, while aticoantral, it is conductive, plus or minus sensory neural involvement because of the invasiveness and more serious type of aticoantral type. It may involve the sensory neural element as well. So it can be conductive purely, or can be a mixed type of deafness in aticoantral type of CSOM. Perforation is usually central in tubotympanic. When you see the tympanic membrane, discharge is coming out definitely, but the perforation is central. What do you mean by central perforation? Central doesn't mean that it is particularly in the center. Central means that it's surrounded by the remnants of tympanic membrane. Wherever there is a center of the perforation, it should always be surrounded by remnants. Remnants of tympanic membrane are still there. But in posterior superior etiquointral type of CSM, which is more serious, the perforation is usually marginal. The location is posterior superior because it's etiquointral type, and it cuts the margins. The remnants are not seen all around that perforation. So that is called marginal perforation, atic perforation, or posterior superior perforation in the type of etiquointral. Complications are rare in tubotympanic type of CSOM, but complications are usually present, common in etiquointral type. It is not treated in time. Investigations in CSOM basically are pus CS, extremastoid. If cholestoma is present, translucent bag would be seen in X-ray. Hearing assessment is done, mostly PT, pure tone audiogram is done. And sometimes CT scan is performed if it is etiquointral type and complications are there. Surgery is the mainstay of treatment in chronic suppurative otitis media. The aim of surgery is to eradicate or remove the disease. Clearing the cholestoma, that is the main pathological entity. We will be dealing in detail in 4 years, and restoration of functional hearing loss. These are the different types of surgery. I'm not going in detail. The complications of CSOM chronic suppurative otitis media can be basically categorized into 2 types: extracranial outside the cranium and intracranial. In extracranial complications, 3 common complications are mastoiditis. The inflammation of the mastoid can lead to mastoid abscess. It can be labyrinthitis when it's going to the inner ear. It causes inflammation of the labyrinth. The 3rd common condition, when the disease erodes the facial canal, it can cause facial nerve palsy or facial nerve paralysis. If it is going to the external ear, it can cause otitis externa, that is inflammation of external ear, petrositis, inflammation of the petrous bone, thrombosis of the internal jugular vein. These are the surrounding complications. But if it goes towards the brain or it erodes the tegment plate, it can cause meningitis, inflammation of the meninges, brain abscess. 2 common parts of the brain which can be involved. Autogenic brain abscess are temporal and cerebellar. Extradural subdural abscess, encephalitis means inflammation of the brain parenchyma, sigmoid thrombosis. The inner ear is, this is a picture of inner ear. There's 3 semicircular canals, and this is the these are the 3 semicircular canals which are concerned with balance. And this is the cochlear nerve, this is the vestibular nerve, this is the vestibule ampulla, and this is the cochlea, in which we have this hair cells responsible for hearing and conducting to the brain main center. So inner ear, when inner ear is involved, the main symptoms of the patients are deafness or impairment of hearing. Tinnitus usually is the complaint of the inner ear, and vertigo, it is subjective feeling of disbalance. Subjective vertigo is the most common condition or most common symptom when the patient is having inner ear problem. There is subjective sense of imbalance, illusion of movement, which should be rotation of oneself or the environment. So these are the basic types of vertigo. Benign paroxysmal positional vertigo is the most common cause of vertigo, and usually patients are complaining then and they move their head, they feel the feeling of vertigo. Ages 60 to 70, female affected twice more. Head trauma is usually a history factor. Dick's Colpig maneuver, it would be demonstrated when you come to ward. How is it beneficial in treating the patient and making a diagnosis of benign paroxysmal positional vertigo. Benign means not serious, paroxysmal means when it comes in frequency, and positional means it is related with change in head positions, and vertigo means dizziness. This is a Colpig maneuver done in steps. which is better demonstrated and involved when you are coming in clinical practice. Meniere's disease is another condition of the inner ear, which is characterized by vertigo, hearing loss, and tinnitus. Cause is unknown, but is usually because of overproduction of the fluid in the endolymphatic compartment of the inner ear. This is the endolymphatic compartment in which the endolymphatic fluid is more produced, and it is characterized by stretching of the rhizomatous membrane, dilatation of scalar media, and the treatment is vasodilators, salt retraction, diuretics, restriction, acute therapy, stabilization, intratympanic steroids sometimes, and for drainage, intertympanic mastoid shunts. Have a nice day. Thank you. Juma Mubarak. I hope you have learned a lot, inshallah, and we will be doing more practice when you come in our wards. Hoping to see you soon. Have a nice day. Thanks, everyone. Do you have any question? Time is over. Thank you.